Thank you, Caroline, and thank you, everyone, for letting me come here and talking about my main interest in life, I would say. It's almost 20 years since we had the first application for our screening study in Gothenburg. So as someone told us before, it's a lifetime effort to do prostate cancer studies if you want to follow on to the bitter end. My topic today is who, when, and how to minimize interval cancers. And I think that is a very, very easy one. And I can give you a very simple question, and I can finish my talk with one slide. If you just want to minimize the risk of interval cancers, of course, you could screen as intensive as possible. You should screen yearly from age 40 to death. So, what is the problem? I mean, the problem is not in prostate cancer screening only to diagnose prostate cancer. We should, of course, have a screening program. This is as efficient as possible to reduce prostate cancer deaths. But we also need a program that minimizes the risk of overdiagnosis. We now know that with PSA screening, we will double the lifetime risk for a man to having prostate cancer diagnosed. So that is one major problem with screening. We must also look on quality of life and, of course, try to maximize that as far as possible with the program, and we should also be cost-effective. When we discuss screening, I think this is somewhat overlooked when the randomized screening studies had been published. I still think this is a piece of evidence that is quite substantial. And as I understand now, the decrease in prostate cancer mortality in the United States is 40%. And that has not, as far as I know, been repeated in any other country around the world. In Scandinavia, we have had a lot of opportunistic screening and so on, but less frequent than compared to the United States. And we see almost no decrease in mortality, and as I understand in the UK, the decrease is somewhere between 10 and 20%, if it's mistaken. Despite this, we all know that the US Preventive Services Task Force 2 years ago recommended against PSA screening. And they did not even discuss this, as I think. They overlooked this. They all built all up on the randomized screening studies, especially the American PLCO study and the European study, the EOSPC study. I will not, and have not time to go into detail, but I think despite that the PLCO is a very well conducted study, it's perfect in many ways, it should still not have been started, in my view. It was started in a situation when you had no fish any longer in the pond. You were not able with a screening program to detect these cancers that will kill. And if you can imagine, the PLCO study had 4 times as many men as the Gothenburg study. But now we have more death in the Gothenburg study compared to the PLCO, telling us that there are very, very few cancers when they started the study. So I will discuss the EOSPC only today. And the last report is now 1.5 years ago, and we are currently working with next update, and it will come probably within a half a year from now. I will not be able to give you any data about that. But I have some other data. As you know, the EOSPC is a study with 8 centers, where each center have a bit different protocol, and it's been criticized for being 8 different studies. I don't mind whether you call these 8 studies under one umbrella or one study. I think it's a strength that we have these differences between centers, which gives us an opportunity to look on how these differences affect the results. In the last report, we had a 21% reduction in overall mortality. Still, the follow-up is short. It's about 5 years, the median follow-up from the detection, from the diagnosis to last follow-up. What also was published in our last publication was this one. It was in the appendix, but it shows interestingly, the large differences between centers, and especially if you look, I have this one to work, but if you look on oh, there it comes, Sweden, we have a 44%. If we compare to our neighbor, Finland, which have the exactly same healthcare system, same type of randomization, similar age, they only have 11 years. So it's a tremendous differences between our two countries. And I will try to give you some data why. First, I should talk about interval cancers. And interval cancers are usually defined as all cancers that surface as clinical cancers between two screening visits. But there are still some discussions. Should you call a cancer in a man who had an elevated PSA but refused biopsy, come back after 6 months outside the protocol, have a new biopsy and have cancer? Is that an interval cancer? And so on and so on. But we used to call all cancers detected outside the program in those who have participated for interval cancers. And we actually had one publication on this, which now is a couple of years old, but where in that paper we compared a 2- and 4-year interval to see whether that affects the risk of interval cancers. And this was published in GNCI. And as you can see, that first thing of all, the number of interval cancers are rather few for prostate cancers, for PSA screening, very few. And you can also see that if you look on those interval cancers we detect, most of them are T1 cancers, T1C cancers, and rather low-risk cancers. Very few which we normally associate with interval cancers with poor prognosis. So the majority of these cancers were men who had opportunistic screening despite they were invited, so they had extra PSA taken between their invitations. We concluded this one that we did not really see any difference between a 4-year interval and a 2-year interval, but there was a small difference, and I think it was maybe a premature conclusion we had. If we looked, for example, on those who had aggressive interval, which are very few, 5 in Gothenburg during 10 years, 15 in the Rotterdam Center, but you see, all ours were in the beginning. They were missed at the initial biopsy, but were found on the second biopsy, extra biopsies. While in the Dutch center, you see they increases over time. So I still think there is an advantage, and I will show more results about that. We have to redo this analysis later. Another important paper for understanding what happens with screening is this paper, which came out in European Urology a year ago from now, where we looked on the transition to M+. So we divided all cancers in 4 of the EOSPC centers and looked on the incidence of M+ disease. And as you can see here, this is the overall, and you see there is quite a difference between the control arm and the screening arm. And this difference is mainly due to what we found at diagnosis. These are those cancers that had M+ as diagnosis, and you see it's much more frequent in the control arm compared to the screening arm. But these are maybe more interesting. These are those who were detected as M0, but progressed to M+ during the study. And you see this is almost the same risk in both arms for this, which was a bit disappointing. When we looked into this, this is a lot of, and what I show you just shortly what it is. This is showing that it was maybe a small difference between the centers, not at diagnosis. About half of all centers, the risk of having M+ at diagnosis, screen diagnosis was about half in the screening arm in all centers. But if you look during follow-up, you see that Sweden have a little better ratio compared to the other centers. So it seemed that the transition to M+ from initial screen detected was somewhere in the range 10 to 20% lower in the Swedish center, indicating maybe that the 2-year interval also is is better. This shows which cancers that progressed to M+, and that you see most of those were cancers detected in round 1 and who were intermediate risk cancers. This is the majority. I thought it would have been these high risk, but if you look on this number, the majority is the intermediate risk cancer. The risk, of course, intermediate risk is lower compared to high risk, but as this group is rather large, it is an interesting group, and there are cancers here which, despite detected in intermediate risk features and detected in a screening program, still are incurable when they are detected. Very few in the low risk. So we can skip that one to save some. We also looked on if this was the result of treatment, and it was, if you are a urologist and do radical prostatectomy, you maybe is happy because there is a little bit advantage for the surgical arm, but you should realize that we have not compensated for age and differences within these risk groups. So I would say that you cannot explain this difference just to differences in treatment. Another important paper we published around this will give you some clue. It is this, which is a year ago in New England, when we did a modeling from the EOSPC data. And we put all the time it comes new results, we put them in the model. So the modeling now is very robust, I would say. What we did in this study was that we compared and modeled different scenarios for screening and looked what is the optimal way to screen. And then it turned out that some very interesting things. The best model would, in our hands, would be if you screen men between the age of 55 to 69 annually. If we compare what happened if we do that annually or every 4th year, you can see that the relative reduction in prostate cancer mortality is much lower. But if you look on this, the number needed to be detected to prevent one prostate cancer death, which is some kind of calculation of over-diagnosis, you see it is actually the same. And that is my true, even if you only screen every 4 years, you still diagnose this large bunch of low-risk cancers. So it's difficult to avoid with a longer screening interval. You can also see that you save most lives, or you save no lives, but you prevent prostate cancer death with, if you screen up to the age of 74, but you will have the same QALYs gained. So the over-detection rises so much, so that it will be compensated for that. I just showed this very briefly because I think this is interesting. This is a sensitivity analysis, and you can see overdiagnosis had different place, but the worst things for the QALYs in a screening program is the side effects from treatment. We have to find treatments with very low long-term side effects because that is the most important things. It's more important than the risk of overdiagnosis. So what is lead time? We usually calculate lead time in the range 8 to 11 years, and you usually say that interval screening interval should be half of the lead time. I think this is a misunderstanding because the lead time includes all cancers, but we are only interested in that 25% of cancers that actually will kill the man. It means it's the fast-growing cancers are at highest risk of killing the man, and we have to look on the lead time of that particular type of cancer, and that is probably much shorter. We have made some calculation, seems to be in the range of 3 years, which stands to say we should have a screening interval between 1 and 2 years. Probably in the future we will have a screening interval risk stratified because of PSA. Coming shortly back to this big difference we saw in different centers in EOSPC, especially Finland, Sweden. And the beauty, this is the Finnish study published this year in GNCI, and this is the Swedish study we published in 2010. You also see now the 2010 year data, and it is still an increasing absolute risk reduction compared to what we published. The relative risk reduction, however, is somewhat going down. The number needed to diagnose is decreasing, as well as the number needing to invite for preventing one prostate cancer death. The beauty with these studies is that they are population-based, so we are able to look on the expected number of men in the absence of PSA testing. How many would have been diagnosed? How many would have died? We have had a very stable situation in Sweden for 20 years, and if we took the data from 1919 to 94, when we have almost no PSA testing, you see also in the control group, we have had an almost doubling of the incidence compared to what have been without PSA. But look, so even if we double the incidence, we have almost no effect on mortality. So the way we have used opportunistic screening in Sweden have been probably make much more harm than good. While in the screening group we have over here, you see we have almost a 50% decrease in mortality. We can do the same for, we can also to look on the Finnish study and compare why is that. And you can see, if we look in the screening group in Sweden again and in Finland, you can see that the efficacy in Sweden is much, much better compared to Finland, but they also seems to have a better effect of their opportunistic screening, or whatever it is, but the mortality seems to go down in Finland. We can also look on all the centers in EOSPC, and we come to the conclusion that the more intense you screen, you can measure the PSA test per invited man, or the biopsies in an average, the mean per invited man. And if you do this, you can see that the more intense you screen, the better your results will be. So to conclude this, I will say that the effect of PSA testing is largely dependent upon how you screen and which population you screen. The rate of interval cancer is a poor indicator of efficacy in prostate cancer screening, but the risk group distribution in repeated screening seems to be a much better way of looking at it. I have not shown these data here. Present study speak against the too limited screening effort. If we screen with too long interval and so on, we probably miss these dangerous cancers. These lethal cancers will be diagnosed too late, but we will still diagnose the large bunch of less aggressive cancers. We will only have the overdiagnostic, but not catching the lethal cancers in time. So the opportunistic screening, at least that has been practiced in Sweden, is inferior to organized screening. The attitude in screening in EOSPC group, as well as it is in Sweden today, is that all men actually should be informed about pros and cons with PSA testing. And if he chooses to be tested, there should be a program for PSA testing, not just now and then without an organization. Thank you very much.
Great. Thank you very much, Prof. Hugosson. I think that it really sets the challenge for how we find the aggressive cancers and don't find or don't treat the non-aggressive. So we do have time for a couple of questions. Simon Brewster, we have a microphone down here, please. And just as a reminder, if you can say your name for the tape.
Well, yes, Simon Brewster from Oxford. Joined us. Very good talk, thank you. How have your government Department of Health reacted to the Swedish cohort results?
Yeah, I can say we do not follow the United States. It seems like we are doing like this. When they are up, we are down, and the opposite. I think that they have looked on our data, and as you know, there is a big screening project going on in Stockholm, inviting 200,000 men. It's still a study. I think the attitude is what we discussed today. If we actually actively should inform men about PSA, it means we send out a letter, this test is available, these are the harms and these are the benefits, it's your choice if you want to take your PSA. And so it's been such activities going on, but at the moment it is like this. If a man comes and says to his GP, I want a PSA, he's allowed to have it if he is well informed. and it's subsidized by the government. But I think we will all soon come into a situation when they look on this, that the organized way seems to be much better. And Sweden always liked organized healthcare system. So I think there will be activities with organized, I don't call it screening, but an offer to be screened at least.
But they're not planning a program right now?
Not for the whole country, no. But in different parts, there are activities going on.
Right. Thank you. And Steve and then Tim. So, question just there.
Thank you. Stephen Langley from Guildford. It's a great talk. Could I just ask 2 questions? Could you give me an idea, or just put in context, of the numbers needed to screen and treat for breast and, say, perhaps colon cancer, and how that compares with the Swedish data now? Because I think it's getting pretty close, if not swapped. And the other question I'd like to ask is, you've shown that the number of times you're screened, then the better you do, I think, and that was one of the explanations between Sweden and Finland. Presumably that's because you have more transrectal biopsies, and I wonder what your thoughts are that if one had a template biopsy or even a multiparametric MRI and a template biopsy on that one occasion, whether that would have a bigger effect and would see the curves separating even greater than them being blind transfecal biopsies, which I imagine most have been to date.
Yes, interesting, both questions. As you compared to breast and colon cancer screening, you can say the efficacy of colon cancer is, rather good because they have no overdiagnosis at all. So the number needed to diagnose is 1 or even less than 1, because they prevent colon cancer by taking polyps away. The number needed to invite is around 1,000 for colon cancer, and in prostate cancer it will be much, much lower. So in that, the efficacy of prostate cancer screening would in that way be better, but we still have this overdiagnostic problem. And we look when we model these data, we found that the number needed to diagnose to prevent 1 prostate cancer will be around 5. In breast cancer, it is usually somewhere between 6 and 12 in different studies, and the number needed to invite for prevent 1 prostate cancer death is probably 100 in a system which is mature enough. In breast cancer, it's different on which age group you have, but around 1,000. So the efficacy of prostate cancer screening is in that way more effective. The problem is still that the overdiagnosis is not the real, as a big problem in breast cancer. They have different problems because they detect them too late with mammography. So that makes why they have a number needed to diagnose that is so high. Why in prostate cancer it's more an expression of the risk of overdiagnosis. So ethically, it's a bit different to compare these 2 data. The second thing is, if you have had 1 biopsy, is that much more efficient than going for a lot of PSA? We had looked on that and looked on all who had 1 negative biopsy. Have they no risk of having prostate cancer? And it is not so. I'm sorry, it seems that you have to have this over time, because these cancers, which we probably prevent the death, is cancers that comes quite quickly. So even if you had a negative biopsy 5 years ago, you are not secure.
Thank you.